further ado, I'd like to hand over to our first presenter, Dr. Joan Luby. This session is on suicide risk factors and prevention. Dr. Joan Luby is the Samuel and May S. Ludwig Professor of Child Psychiatry at the Washington University School of Medicine, where she founded and leads the Early Emotional Development Program. She specializes in infant preschool psychiatry, and a program of research is focused on early childhood affective psychopathology and emotional development over the 30 years. So I'll hand over to Joan. Thank you.
Thank you. Okay. Let's see, I'm trying to share my screen. I'm guessing you can't see the screen right now. There we go. Can you see the screen now? Can you see?
Yes.
Okay, great. All right, it's an honor to be here, and I'm guessing this is going to be a somewhat surprising and unusual talk because when we think about child death and suicidality, we don't tend to think about it in early childhood. But this is a finding that we sort of stumbled upon as we were studying preschool depression, which we've looked at over the past 30 or so years. So as way of background, I just want to sort of tell you a little bit about the fact that we now really do know that clinical depression can arise in children as early as age 3. This is something probably prior to 1990 that was unrecognized and is still under-recognized, but this has been studied in numerous independent study samples from all over the world, the United States, Canada, Norway. And we know that these children basically meet DSM-5 criteria for depression with some age adjustments to those criteria. These kids have biological markers similar to the markers that are established in depressed adults, like alterations in stress responsivity and neural response to reward. We know they come from families with higher rates of depression, and it's not just that their parents report them as depressed. We see evidence of this when we observe their behavior. We also know it's clinically important because these kids are impaired in multiple settings. And as I said, they've been detected in a number of epidemiologic samples worldwide, and the prevalence rate is about 1 to 2%, which is very similar to the prevalence rate of prepubertal depression. So preschool depression, again, often under-recognized because these kids tend to be withdrawn, internalizing, they're not troublemakers in the classroom. But the things we want to look for are kids who have negative self-esteem, they feel like they're not liked. Sometimes they have passive thoughts of death, like I wish I was never born. They have the symptom of anhedonia, which is a starkly abnormal symptom in a preschooler. It's because preschoolers are so inherently joyful. They also have elevated levels of guilt, and surprisingly, they have suicidal thoughts and sometimes behaviors. Now, when we first launched our first study of preschool depression, we weren't really looking for suicidality, but we ended up finding it and were very surprised by the rates that we found. When we launched a larger scale study of preschool depression, we found much higher rates of suicidality, and perhaps we were also asking about it more carefully. But when we look at a sample of depressed children, this is a sample of about 250 depressed children, we found about 48% prevalence rate of suicidal thoughts and behaviors. Most of this was passive suicidality, like I wish I was never born, a smaller percentage active suicidality, and then suicidal behaviors, which could be self-harm, putting things around kids' necks, jumping from high places, etc. So one of the things we really wanted to understand when we saw this in these 4 to 6-year-old children is, did these children who were having suicidal ideation or thoughts have an understanding of death? Because many people tended to discount these expressions in children because they felt young children really didn't understand death. Well, what we found is that depressed kids who had suicidal thoughts and behaviors had a more mature understanding of death relative to healthy peers and depressed peers without suicidal thoughts and behaviors. We also found using things like narrative and story stems, where a child is given the stem of a story that's sort of emotionally evocative, and then they complete the story, that they have more violence and suicide and conflict resolutions during their narrative play. So one of the things, we actually did do interviews that really looked at children's understandings of death. These are basic developmental interviews. And we see that depressed kids who have suicidality understand the components of death almost across the board better than depressed kids without suicidality and healthy controls. They understand the universality of death. They understand that non-living things don't die. They understand that death is irreversible. They understand that in death, bodily processes cease to function, and they understand what kinds of things cause death. So this really dispels the myth that when children make these expressions at this early age, that they're not understanding what they're talking about. So one of the things that we then found when we followed up a sample of depressed preschoolers who had been engaged in an early psychotherapeutic treatment study is the depressed preschoolers who had suicidal thoughts and behaviors had a much higher rate of having suicidal thoughts and behaviors when they were pre-adolescent and school age. And this just sort of gives you the odds ratios of just how much higher the rates of suicidality were in kids who had this history from the preschool period, suggesting, again, that these thoughts and expressions are not just transient and go away. They seem to predict a sustained preoccupation with suicidal thoughts and behaviors. So again, this is a study where we followed about 137 of our 250 children up at age 8 to 12. These children were all previously depressed. They'd all participated in a treatment study, and there were also some income match community controls. So to summarize, we know that the kids who had preschool onset depression were 7 times more likely to have suicidal thoughts and behavior at the pre-adolescent follow-up, and 6.7 times more likely to have behaviors and attempts. So here we see a very powerful signal for later dangerous behaviors, because of course suicidal thoughts and behaviors when at age 8 to 12 are much more likely to lead to lethality than they are at age 4 to 6, although they can lead to lethality at age 4 to 6 too. So these findings held when we controlled for externalizing comorbidity and family history of suicidality. And there were similar outcomes in the kids who had depression who did not have suicidal thoughts and behaviors, suggesting that depression in the preschool period is a powerful risk factor for suicidal thoughts and behaviors at age 8 to 12. We also know that preschool depression is a risk factor for experiencing STBs in adolescents. And looking at it in more detail, we see that it's a generalized risk factor, but kids who had passive suicidality, of course, are this is a much more frequent occurrence. And this just also tells you basically the rates of active, passive, actual suicide behaviors and attempts. And you can see that these rates go up pretty substantially when these kids are young adolescents. Okay, so, and this is just sort of correlating the difference between kids who had suicidal thoughts and behaviors during the preschool period to those who were depressed who did not have suicidal thoughts and behaviors during the preschool period. And we see that those who had suicidal thoughts and behaviors have higher rates than those who didn't, but they both have elevated rates. Let me skip over this slide. So let me tell you a little bit about the treatment, because these data were derived from a treatment study. And this treatment study was one where we collected a large sample of depressed preschoolers, and then we randomized these families, dyads, caregivers, and children between the ages of 3 and 7 to either having immediate treatment or being in a waitlist control condition and then having treatment subsequently. The treatment we administered was a variant of parent-child interaction therapy, which is a widely known therapy utilized worldwide, originally designed to treat disruptive behaviors. We modified this therapy and added a module called the Emotion Development Module, which was designed to address mood dysregulation and depressed mood. What's interesting about this therapy is that it's done by having the caregiver wear a bug in the ear and having the therapist coach the caregiver during live, sometimes emotionally hot interactions with the child. So the emotion development treatment targets were to have children learn to accurately identify and label a broad range of emotions in themselves and others, to learn adaptive strategies to deal with guilt and utilize proactive guilt reparation. I think I mentioned that guilt is a hallmark of preschool depression. Pathological guilt, feeling guilty for transgressions you didn't commit, feeling guilty and having trouble getting over that guilt. Another aim was to learn to regulate intense emotions by utilizing cognitive control strategies, and to learn to focus on positive events and sustain positive emotions. We know depressed individuals have a hard, in addition to feeling excessive amounts of negative emotion, they have a harder time sustaining positive emotion as well. So what the ED module does is it provides evocative events in vivo during live coaching. So what's different about this than a standard psychotherapy, where people come in to see their clinician and they talk about an emotionally difficult event that happened 2 days ago or last week, when it's just a memory, it's distorted by their memory, and it's not sort of active and live. Parents are then coached during these active, live, emotionally hot interactions. They're taught to tolerate the child's expression of intense emotion, particularly intense negative emotion. They're taught to validate the child's emotion before attempting to fix or regulate the emotion. For example, we try to teach parents to not say, don't cry, or there's nothing to cry about. It helps the parents to accurately identify and label emotions in self and others. So the parent serves as the child's external emotion coach, essentially. And this just sort of shows you some of the various, it's a schematic of some of the things we target. So one of the things that this treatment did is it changed parenting behaviors pretty dramatically in the expected direction following the treatment targets. Parents who underwent the PCI-TED had much lower rates of parental minimizing. They tended to, because we directly taught parents not to minimize a child's emotion. They also had much higher rates of expressive encouragement. They were encouraging children to verbally express their emotions. They had lower rates of parental distress in response to a child's intense expression of emotion, and they had lower rates of parent emotion-focused reactions. So they tended to actually get the child to focus on emotions and not so much focus on their own emotion. So one of the things, the reason why I'm telling you about this treatment is because we see that the children who underwent the treatment actually had, if you responded to treatment, if you were in remission at the end of treatment, and about 50 subjects were in remission compared to 7 who were not in remission, we see that your rates of having STBs when you're 8 to 12 are much lower, suggesting that this approach to emotional expression actually lowers the child's rates of STBs. So to conclude, we know that depression appears in preschoolers as young as age 3. It is identified by typical DSM-5 markers of depression, but they need to be developmentally adjusted. And there are many diagnostic psychiatric interviews now that do just that and that can be used both clinically and in research. So step one, I think, is to begin to identify this disorder in early childhood. We now have a treatment, which is a psychotherapy that is proven effective, at least in one large-scale RCT, that we know produces remission of depression. We actually have data that we're working on right now that shows it produces sustained remission even into adolescence. And it also tends to decrease the later occurrence of suicidal thoughts and behaviors. So this holds when other known predictors are controlled in the analysis, suggesting this is an important thing to attend to prevent the onset of suicidal thoughts and behaviors in early adolescence. Depressed preschoolers without suicidal thoughts and behaviors also have a higher risk of early adolescent suicidal thoughts and behaviors, although those with early suicidal thoughts and behaviors have the highest risk. We know this early intervention that focuses on enhancing the child's emotion development, that is, ability to express a broad range of emotions, to tolerate and regulate intense negative emotions, and to help the caregiver mentor the child in doing that, decreases risks. And the results suggest that clinicians should attend to early suicidal thoughts and behaviors and early onset depression to prevent adolescent suicidal thoughts and behaviors. So with that, I will open for questions.
Thank you very much, Joan. Thanks for sharing your knowledge. We're really appreciative for you taking the time to join us. We've had a couple of questions online. So the first question is, what are the proportions of preschool-age children with a single diagnosis of depression versus those with other comorbidities?
Very good question. About 45% of children with preschool depression have other comorbidities, most often disruptive behavioral disorders and anxiety disorders.
Thank you. The next question, if we were to consider early intervention, does your research show the drivers of depression in preschool-age children? Are they more likely to be predisposed to depression due to personality types or genetics? Or is it more a response to environmental and situational factors?
That's a very good question that my research and the research, and really the research that's available that targets preschool depression specifically really has not answered. We did not have a genetically informed design. I mean, we certainly know from other studies on depression that there is a role for genetics and there is genetic heritability, but we also know there's a role for environment as well. So that's really an unanswered question that this program of research does not inform.
Thank you. I have another question. Did neurodiversity feature in the children? So ASD, ADHD.
So kids with ADHD were included, kids with ASD were excluded. And that is pretty typical in treatment studies that we do, just because kids with ASD tend to need different types of approaches. And then you have a range of verbal comprehension capacities, there really is a certain level of verbal proficiency and social proficiency that is needed to do well in this particular treatment.
Thank you. I have a couple of questions in the chat as well. So do you know what percentage of adolescent suicidality have indicators of early STB?
I don't know that people have looked at that. I think that's a really good question, because really until very recently, the assumption has been that children under the age of 8 didn't have STBs. And in fact, right now, the recommendations are that we should screen kids for STBs 8 and older. We feel very strongly that certain kids younger than age 8 need to be screened. But I think these are not questions that have been asked or considered. But I do think retrospective studies of that question would be a very important thing to do. I'm not aware of any that have been published.
Thank you. So I'll keep going through the questions if that's okay.
Sure.
How can we adapt what you have learned into preschool teaching to maximize prevention?
That's a great question. I mean, there are adaptations of PCIT that can be used in preschools and that are designed for teachers, TCIT, teacher-child interaction therapy. I do think the ED module could easily be adapted to be used in a school setting. We have done some studies where we've used shorter forms of PCIT in school settings delivered by school counselors. We're actually doing a large-scale trial of that right now. But the ED module is available online through the EEDP website, which is www.eedp.worcester.edu. So it's really available for anybody to download and adapt as they see fit.
Great, thank you. How were the social determinants of health considered in this work?
Well, I think the social determinants of health are really, really critical. And one of the things that we learned when we were doing these preschool depression studies is the very, very powerful effects of social adversity on outcomes and particularly on brain development. We were studying in the sample of depressed preschoolers prior to this treatment study. We've done a longitudinal study of depressed preschoolers who we followed for almost 17 years. In that study, we were looking at the effects of preschool depression on neurodevelopment and brain outcomes. And we found effects of preschool depression on neurodevelopment and brain outcomes, but we found even more powerful effects of social adversity on neurodevelopment and brain outcomes, which has led us to launch new studies where we've begun in utero, and we've looked at the effects of social adversity on brain development starting in fetal development, and we're currently following that right now. So I think that has a huge impact. How that signal interfaces with depression and suicidality specifically is not yet clear, but I definitely think it plays a role.
Thank you. I've got one more question in the chat before I jump back to the Q&A.
Sure.
So one of your slides on the understanding of death used only relative measures. So what were the absolute numbers and rates here, please?
That I can't tell you that offhand, but that study is published, and it's going to have, in the paper will have the absolute rates, and I can either send that citation to Emma that she could send around, or you could also Google search it. The first author is Laura Hennenfeld, Hennenfield. And it's probably one of the only papers about preschool depression and children's understanding of death.
Great, thank you. We'll get that out to attendees. Okay, I've got two more questions in the Q&A. Could you provide examples of how suicidal thoughts are expressed by preschoolers and early primary, given their level of development, please?
Yes, that's a good question, and a lot of people ask it because it's very, very hard to imagine it. But, because of course there are the verbal expressions like I wish I was dead, or I wish I was never born, or I want to kill myself in a fit of frustration. But the actions, I think, are what tends to be even more alarming. And we've certainly seen kids wrap things around their neck. We've seen kids jump from high places very deliberately, run out into traffic very deliberately. I mean, things like banging your head against a wall when you're in a fit of rage, and you're sort of expressing that you want to hurt yourself are what we might call self-harm. I wouldn't necessarily classify that as suicidal thought per se, but it's certainly a dangerous self-harm type of action. And we've also seen young children do things like scratching themselves, making their skin bleed, not necessarily cutting, something we see in older age groups.
Great, thank you. Was there a higher proportion of children with STBs that experienced guilt?
That's a really good question. And yes, guilt does seem to be a predictor of later STBs. And we actually are working on publishing some of that data right now. Guilt and shame in early childhood is a powerful predictor of later STBs in depressed individuals. Yes.
Great, thank you. And I'll make this the final question from the chat. Are there any implications for interventions targeting parenting, parent-child interaction in early adolescence?
I mean, I do think some of these same principles of emotion development could apply to early adolescence, because that is certainly a time when children are undergoing a surge of intense emotions that they don't necessarily know how to express, when parents and children tend to be more alienated or disconnected from each other. So whether that would happen between a parent and a child, or a child and a peer, or another caregiver, but I do think these principles of emotion development and emotion intelligence would be an important preventive intervention in adolescence as well.
Great. Okay. Look, thank you so much. Thanks for sharing your insights. A really, really thought-provoking presentation, and obviously your research has had a profound impact on the prevention strategies and messaging. So thank you so much for your time and sharing your expertise with us today.
Thanks for having me.